regarding the benefit of this medication over warfarin in terms of thromboembolic prevention and reducing the number of bleeding in patients with atrial fibrillation. However, this agent, the utilities of this agent in our country is not well supported by the insurance system. Therefore, the utilization is still challenging. So it is an honor for me to introduce two distinguished speakers who will broaden our knowledge regarding applying real-world evidence of NOAC in AF patients. Let me introduce you to the first speaker of our event today. The first international speaker is from Australia, Prof. John Amarina. He is an associate professor from Deakin University and currently works at St. John of God Hospital in Geelong, Victoria. Especially in heart failure. To present in this forum, Professor Amarina. So without further ado, I will invite Professor Amarina to give a lecture with the title of Applying Real-World Evidence of NOAC in AF Patient into Clinical Practice. To Professor Amarina, the time is yours.
Okay, thank you very much for inviting me to come along and speak tonight. Unfortunately, I wish it was in person, but traveling's not really on the agenda at the moment. I'm just trying to get my slides up. There we go. Okay, so basically my brief tonight is to basically talk to you a bit about real world evidence and how it applies in our, and what it adds to our clinical trial knowledge about the NOACs, and in particular we're focusing on Apixaban tonight. So my disclosures are here, and I've been lucky enough over the years to have worked with all of the companies that make the NOACs. I was on the steering committee for both for the RELY study and for the Aristotle study, and an investigator for all three, as well as the rocket study. So to give you a little bit of background, this is data coming from an Australian centre in Adelaide, basically looking at the relationship between stroke, type of stroke, and age. And as you can see, as you get older, the incidence of stroke increases, and as you get older, the type of stroke or the cause of stroke, cardioembolic stroke, increases dramatically. And so the majority of these strokes are from atrial fibrillation, and many of them are preventable. So that's really where our focus is. Unfortunately, strokes related to atrial fibrillation really tend to be very large strokes, and this is a left atrial appendage. This is a big thrombus at the origin of the left atrial appendage, and if you can imagine, if this embolizes, it causes a big stroke. And in fact, when you look at the data, that the strokes, the mortality after stroke at 30 days, and 1 year, are much higher if you have a stroke related to atrial fibrillation than other forms of stroke. So really, the strokes in AF are large, nasty, fatal in many cases, and if they're not, they're more disabling than they are non-AF related strokes. And as you can see in the black bars, this is the severe disability in the acute phase, 3, 6, and 12 months. At any stage after a stroke, you're more likely to be dead or disabled if your stroke's related to AF. The typical scoring system we use to determine who should be anticoagulated to reduce the risk of stroke is either the CHADS score, but to a large extent it's been supplanted by the CHADS-VAS score. And you can see from the diagram that they basically look at a risk per annual risk of stroke according to the risk factors outlined here: heart failure, hypertension, age over 75, diabetes, and stroke. And then CHADS-VASc adds in vascular disease, age 65 to 74, and gender. The advantage of CHADS-VASc is it really is very good at identifying the truly low-risk patient who you don't need to anticoagulate. It's got much more discriminatory ability than the CHADS-2 score in looking at that low-risk population. When we consider anticoagulation, we want to prevent strokes, but we don't want to do so at the risk of bleeding, and that can be bleeding in the periphery, internally, and what's most feared is intracerebral hemorrhage. And this is the consequence of warfarinization to a large extent. There's an increased risk of intracranial hemorrhage, and as you know, and we'll discuss later, this tends to be more of a problem in Asian populations than in Caucasian populations. So it's really a very worrisome and limiting factor when we're considering anticoagulation in patients who have a higher risk of stroke, but they also have a higher risk of bleeding, particularly intracranially with warfarin in Asia. So this is the NOAC trials over the years, and the first was the RELY study, came out in 2009, followed pretty quickly a couple of years later by Rocket, Aristotle, Engage, and then a variety of meta-analyses. And this basically, despite these studies coming along, the uptake by the august authorities of the ESC, American Heart, ACC, Heart Rhythm Society, were pretty slow on the uptake of recommending these agents to be used in preference to warfarin. The studies we'll just look at very briefly, just to give you a snapshot of what they are. The first study was with dabigatran, which is a direct thrombin inhibitor. In the RELY study, 18,000 patients, a probe design. That means basically that the prospective randomized open endpoint blinded, open label blinded endpoint. So we knew what the patients were getting, they didn't, and basically the adjudicators didn't know either. So it had a mean CHADS-2 score in those days of 2.1, bleeding versus stroke and systemic embolism. Rocket AF chose a higher risk population so that the CHADS-2 score was 3.5, and the efficacy endpoint was pretty much the same, but the bleeding endpoint was a little bit different. The Aristotle study, 18,000 patients. This was a double-blind study, and it was much more difficult to run as an investigator because you had to do sham placebo, sham INRs, and there was a lot of messing around. But it was it's statistically a bit more robust than a probe design. Anyway, the primary efficacy endpoint was the same, as was the bleeding endpoint in RELY. So this is not head-to-head comparisons, but this is just looking at the relative benefits of these agents compared to each other. So the 150 milligram of dabigatran, a reduced stroke and had pretty similar bleeding compared with warfarin. Rocket, same efficacy, same bleeding. Apixaban, better at reducing stroke than warfarin and less bleeding. And Engage, the doxaban 60 milligrams, was basically pretty much similar to warfarin but less bleeding. Overall, a marked reduction in stroke and a marked reduction in bleeding. Another way of looking at it is outlined on this slide. So if you look at the data on Apixaban from the Aristotle study, superiority for the primary endpoint, superiority in major bleeding, and superiority in all-cause mortality. So that's a pretty good profile for an anticoagulant. The dabigatran 150 was superior in terms of stroke. The dabigatran 110 was superior in terms of bleeding. Rivaroxaban basically was pretty much the same as warfarin for all of the endpoints. So that's fine in the big study, but what about in an Asian population? We you're in this area that's included. Unfortunately, Indonesia wasn't in the trial, in the Aristotle trial, but I think the data I'm about to present is quite relevant to you guys. So this is a sub-analysis of patients from East Asia that were in the Aristotle study. So to give a bit of background, warfarin use in East Asia with AF is less than in North America and Europe. And we know that and we accept that. We know that the studies that have been done prior to these, there wasn't a lot of representation from Asian countries. And as I mentioned before, we appreciate that East Asian patients have a higher risk of intracranial hemorrhage with warfarin, despite similar INR control to non-Asian populations. So we think there is an increased risk of ICH, and that's particularly problematic with warfarin. The other background in Aristotle was compared to low dose, Apixaban was compared to warfarin with a target INR 2 to 3. So that's sometimes a bit higher than traditionally what's aimed for in Asia. We showed in the study there was superior efficacy and safety, as I just showed you a few slides ago. And we wanted to then look at the East Asian subpopulation. So analysis was looked at this and the baseline characteristics, concomitant medication use, warfarin control by time in therapeutic range, and the effects and safety. So just to give you a refresher on what the study involved, basically patients over 18 who had to have non-valvular AF and one or more risk factors for stroke were randomized double-blind, double dummy to Apixaban or warfarin. Apixaban had a dose reduction in about 5% of patients who had two of the criteria of being older than 80, weighing less than 60 kilograms, or having a serum creatinine of greater than 133. Warfarin was the target INR with 2 to 3. The exclusions, previous ICH, stroke within 7 days, dual antiplatelet therapy, and these are the endpoints in the hierarchical order of ascertainment. So these are the countries that were involved. So as I said, unfortunately, Indonesia wasn't, for reasons I'm not clear to me, but China, Japan, South Korea, Taiwan, Philippines, Malaysia, Hong Kong, Singapore. So I think it is relevant to your population. So around 2,000 patients were enrolled from East Asia. The comparisons here are just illustrative to show you what the differences were. So in East Asia, their patients were a bit younger. They were a bit lighter in body weight. The CHADS score was similar. CHADS VAS score was similar. Dose reduction criteria was similar. The prevalence of my prior MI was lower. History of falls lower. Paroxysmal AF higher. Previous stroke and TIA higher. Hypertension and heart failure lower. So there are some meaningful differences within the populations, and it probably just reflects the different disease prevalence in Asian versus non-Asian countries. So in patients who were randomized to warfarin, the time in therapeutic range was lower in East Asia compared to non-East Asian countries, and that was expected. We know the intensity of anticoagulation is not as great in Asian countries because of the fear of intracranial hemorrhage. So we found also, however, that the number of INRs taken during the study was lower in East Asia than the rest of the world, and that the time with the INR less than 2 was longer than in non-East Asian patients. So less testing, less aggressive anticoagulation, and less time in the therapeutic range. That was results that weren't particularly surprising to us. But what was surprising is looking at the efficacy in bleeding. So the dark lines are basically the solid lines are Apixaban and warfarin, and you can see that there was a marked the incidence of stroke and systemic embolism was significantly higher in the East Asian population, and the magnitude of benefit was substantially greater than in the non-East Asian. So more strokes, but greater benefit by using apixaban in this population. In terms of bleeding, again, we saw that East Asian patients on warfarin had substantially greater bleeding than patients on warfarin in non-Asian countries, and the magnitude of reduction in bleeding was greater with apixaban in Asian patients than in the non-Asian patients. So more strokes, better relative and absolute efficacy, more bleeding, but much better in terms of reduction of bleeding. So that, again, is a pretty attractive profile for an anticoagulant in an Asian population. To summarize, the stroke rate was higher. We've been through that. Their consistent benefits were the same as we saw in the whole study, and the tendency for a greater reduction in non-major bleeding, and certainly intracranial bleeding, I haven't shown you independently. And basically, there was an interaction, basically, that the patients in East Asian countries had larger reduction in bleeding than patients in non-Asian countries. You're not supposed to read this slide. This is a paper that was published by Greg Lipp, but just look, Asians are in red and non-Asians in blue. And you can see for just about every endpoint, the NOACs going across dabigatran 150, 110, rivaroxaban, apixaban, edoxaban. So just about for every endpoint, there was greater benefit of NOAC use in the Asian population than in a non-Asian population. So in conclusion, the Aristotle study had around 2,000 patients from East Asia, by patients with lower body rate and poorer INR control. The overall stroke risk was higher in Asia than non-Asia. Apixaban had consistent benefits, a greater reduction in bleeding with apixaban in Asia compared with non-Asia. Rates of intracranial hemorrhage were higher in East Asian patients despite lower INR control, and it really supports the apixaban being an attractive option. So just to change tack a little bit, that's the data in Asia, but we're often tempted, as I showed you before, that AF related strokes increase fairly dramatically as people get older. The benefits of anticoagulation are preserved in the elderly, but we always worry that our older, frailer patients could have a fall, have marked bleeding, develop a subdural hematoma if they hit their head. And so we often opt either to not anticoagulate them or use aspirin. This study is often quoted, and basically they looked at the net clinical benefit of anticoagulation versus not in elderly patients who were at risk of falls. And they calculated that you'd have to fall about 300 times a year to make warfarin more dangerous than being on nothing at all. So basically they're saying even if you fall fairly frequently, that the benefit is, if the net clinical benefit is in favor of warfarin, unless you're having 295 falls per year. So that's pretty sobering. The other study that we looked at showed that the risks of falls and major bleeds in patients on oral anticoagulation. So the solid line is high risk of falls, the dotted line is low risk of falls, and you can see that basically there wasn't any difference in major bleeding events over the course of a year and a half. So basically, again, suggesting that for a falls risk is a relatively low risk factor in consideration of anticoagulation. We often, in these patients, however, tend to use aspirin, and as an alternative, we think, well, it's safer than an anticoagulant. It's not going to cause as much bleeding, but will give them some protection. And that was really outlined in the Garfield study, and I'll show you some more results from that later. But Garfield took 5 cohorts of newly diagnosed patients with AF from all over the world and basically said what anticoagulation or antithrombotic therapy they on, and looked at their clinical course over a 5-year period. So this is looking at what happened in Asia versus the rest of the world in terms of antithrombotic therapy at various levels of CHADS score. And as you can see in CHADS 0, basically most patients had very few patients in Asia got an anticoagulant, about half in Europe did. Once they came to CHADS 1, more patients got on anticoagulation in Europe than in Asia. And for CHADS 2, it was basically a lot more in Europe and only a few more in Asia. On the other hand, many patients with CHADS 0 got aspirin. In Asia, there was a bigger proportion of aspirin than in Europe, and in CHADS 2 or above, still there was many more patients who received aspirin than anticoagulation. So that was the pattern of antithrombotic treatment from Garfield from nearly 8 years ago. Unfortunately, aspirin really doesn't do much at all. So this is looking at data from 96 to 2011, published in Circulation, and looking at basic ischemic stroke, ICH, in patients who were on antiplatelet drugs or warfarin, so unadjusted, adjusted, whatever. Basically, aspirin made no difference, significant difference in reducing stroke compared with warfarin. ICH, there was not a great increase with aspirin, but there was with warfarin. So really the message is that aspirin really is not a sufficient antithrombotic treatment to prevent strokes in patients with non-valvular AF. Apixaban, however, is, and this is a study that compared patients who were elderly, average age of 70, and they were randomized to either aspirin or to apixaban to determine the relative efficacies of both. The study was stopped prematurely because the patients who received apixaban, in the dark line here, had such a significant reduction in stroke over the 18-month period that the clinical, the DSMB said you cannot continue this trial because the benefits are so great. What surprised us to some extent was that the bleeding between apixaban and aspirin was really pretty comparable. So this was, I have to admit, was unexpected, but it basically showed that in an older population that the bleeding risk between aspirin and apixaban is pretty similar, and that was reinforced in one of the big studies we looked at using apixaban post stenting and dual antiplatelet therapy. So the message is that if you're concerned about a patient's frailty, propensity to falls, and you consider using aspirin, you can use apixaban just as safely with terms of bleeding risk, but you'll get much greater efficacy in terms of reducing stroke. So the second half of the presentation is really talking about real world evidence and how it fits in with our clinical practice and how does it support the studies that we've come in, really pretty selected patients who are heavily scrutinized and are really monitored very closely. So this is the FDA's brief or advice regarding real world evidence. And they've said basically the FDA uses real world data and real world evidence to monitor post marketing safety and adverse events. The healthcare community is using the data to look at the effective medications that are on patients who would not have got into the trials, but we see in everyday practice. And there's also a benefit in designing clinical trials to answer more clinically relevant questions. This gentleman has really quoted, has been quoted quite a bit, and he said the use of real world data is vital if we are to build the services and therapies of the future on a solid foundation of evidence and clinical outcomes. And that pretty much sums it up. It's complementary information to the clinical trials. So this is the sort of data we look at. We've got the randomized clinical trials in a tightly controlled, highly scrutinized, selected population. That translates into approval for the agent to be used on patients in the community. We see patients who have who would not have got into the clinical trials because of exclusion criteria, but they're sitting there in front of us. They're at risk of a stroke, and what we want to be sure of is the data we've got from the clinical trials can be extrapolated into these other patients, and that's where real-world data is very beneficial. We can look at alternative comparators and you'll see some data on that later. You can look at different outcomes in different settings. So it really says, can we translate the results of clinical trials into clinical practice? There is some data that really suggests that these real world studies and data analysis and safety signal collection is important, because we've had some issues with medications in the past that have got through the big clinical trials, and side effects and interactions were not picked up in the clinical trials because they're uncommon and we didn't test enough patients. So we had a calcium channel blocker, mebafridil. It was very good for blood pressure. It was had a huge promotional campaign at the European Society of Hypertension until it was recognised it caused ventricular tachycardia. So it was off the market within a month of getting on the market. Cerevastatin was a really potent statin, and it unfortunately had an increased risk of myopathy, myositis, rhabdomyolysis, so it didn't last too long. And then there's old drugs like methotrexate that we wouldn't use now, but retroperitoneal fibrosis became apparent, and really that was only picked up in post-marketing surveillance. So it really is important to have a mechanism to look for uncommon drugs. When we tested, say, in Aristotle, 18,000 patients, when it gets into the market, you're going to have 18 million patients on it. So the rare side effects won't show up in the clinical trials and can only be picked up in real-world data and post-marketing surveillance. So how can real-world data complement clinical trials? Well, these are the two sort of sides of the coin. So randomized clinical trials, high level of evidence, whereas real-world, more generalizable results. Clinical trials, controlled, randomized, unbiased populations. Real-world data more representative of what we see in the real world. The clinical trials are the basis for regulatory approval, and the real-world data is the basis for interpreting clinical practice, and randomized trials are basis for treatment guidelines, and real-world data is basis for generating hypotheses to be studied in the future. These are some of the types of real-world data that has been studied and published. So we have non-randomized single-arm cohort studies, disease-specific registries, retrospective cohort studies, non-traditional randomized clinical trials or pragmatic trials, and then the traditional randomized trials. So they all have their advantages and disadvantages. And so we'll just talk a little about that before I present some of the data from the clinical trial, the real-world data studies that support the use of NOACs in the broader populations. So there's strengths and limitations. The strengths of real-world data is its effectiveness and safety in real world. Databases are large, so you're talking about, instead of 18,000 patients, you're talking about hundreds of thousands or millions of patients. You're looking at patients who you would not have got into the clinical trials. You can look at a broader set of outcomes, and you can have a longer term follow-up. The limitations is there's the potential for bias because it's not randomized. There's confounders that you sometimes are unaware of and can't adjust for. There's study associations that say these things are linked, but there's not a cause and effect is unable to be definitively shown. coding errors, so good data in equals good data out, and the opposite is true, unfortunately. Lack of appropriate comparators, so you're comparing two things that may not be quite comparable. Data source and type may limit the generalizability in that many of the studies, say in America, are from patients who have private insurance. So as the data from those insured, perhaps more well-educated patients, applicable to the uninsured, perhaps less educated patients. And there's no control. You no control for other interventions. But they can show, real world data can show um, uh, differences between the decisions and enable us to answer questions, particularly in this field. Biases, we mentioned before, these are the sort of biases you see. So attrition bias, the difference in follow-up and duration between groups, indication bias as to why a physician chose this drug as opposed to that drug. We can't ascertain that in general. And selection bias, looking at different subgroups that may not be very well matched. The statistical methods of getting around this are pairwise censoring, but probably propensity score matching and sensitivity analysis are the two areas where we basically use to try and minimize the bias and exclude the confounders. So just to give you a little look at propensity matching, you basically you try and mimic randomization and match patients who have similar risks, similar characteristics, and receive different treatments. So you take the more medication use, comorbidities, CHAD score, etc., and then you do a multivariate logistic analysis, and you try and match the patients. So you can say, this patient and this patient are fairly similar in their characteristics. One received this intervention, the other received another intervention, and is there a meaningful difference in outcome, bleeding, or whatever you choose, whatever parameter you choose to examine. So basically, where we end up is that we've got real world data is certainly a lower level of evidence than randomized clinical trials. Cohort studies are, whether retrospective or prospective, are better than case controlled studies. They're better than case series, and probably the lowest rung of evidence is consensus opinion. But unfortunately, there's many things in medicine where we don't have clinical trial data on which to base our judgments, and we have a consensus of key opinion leaders or experts who give their opinion as to what they think is the most appropriate at whatever stage of the disease understanding. And so there's a lot of things we do that we really don't have hard clinical trial evidence to support our decisions. So this is some of the data that I'll show you now, looking at the real world studies and saying, does it support what we saw in the trials? And this is TrueVin market scan. So this is a large database from the US looking at patients who had had insurance, who were Medicare, and looked over at years 2013, looked at patients who were anticoagulant naive, started on Warfarin, rivaroxaban, dabigatran, or Apixaban, and we're interested primarily in safety in these studies. Outcomes are a bit more difficult to ascertain. And we see in Aristotle, the bleeding was significantly less with Apixaban compared with Warfarin. In the real world, more bleeding with Warfarin and even greater benefit from being on Apixaban. So the bleeding in the real world and the clinical trial was the same, but Warfarin bleeding was much higher because we know that particularly in the States, anticoagulation is often far less than ideal with Warfarin. Another analysis looking at patients who had non-valvular AF, electronic health records, basically looking at bleeding again and saying that rivaroxaban and Warfarin had pretty similar bleeding profiles over about a 6-month period, whereas Apixaban and dabigatran had less bleeding. So again, pretty much what we saw in the trials, supported by what we saw in the real world data. This is a difficult slide to read, but this is looking at a real world setting comparison of non-vitamin K antagonists. So in this case, Apixaban versus Warfarin. And basically the top panel says ischemic stroke, so it's similar, tending in the right direction. Ischemic stroke or systemic embolism, again similar, and any stroke or systemic embolism was superior with Apixaban over Warfarin, which is what we saw in the trial. In terms of safety, far less intracranial hemorrhage, far less gastrointestinal hemorrhage, far less major hemorrhage, and far less death. So really this analysis of sticking all these real world studies together really confirmed what we saw in the Aristotle study. This is another study basically published by Greg Lippin Stroke, effectiveness and safety of oral anticoagulants amongst non-valvular AF. It's impossible to read, but basically the red line is the Apixaban, the dabigatran, and rivaroxaban, and you can see for Apixaban consistently lower risks of overall stroke, intracranial hemorrhage, GIT, major bleeding, and in particular GIT bleeding. So again, what we see in the real world data is what we saw in the clinical trials. Again, from the same paper, looking at Apixaban versus Warfarin, the dabigatran Warfarin, rivaroxaban Warfarin. So we're focused on Apixaban. You see basically that we see considerably less bleeding and so stroke and bleeding with Apixaban. In terms of the bleeding, compare the head-to-head comparisons, I think that's probably not a really valid way of looking at it. But again, the clinical trials is supported by the real-world data. What about the independent studies that have been done with a couple? There's also been studies done in other jurisdictions, and this is a particularly interesting one. It's patients who are in Norway and looked at the population, 30-odd thousand patients, random, who were treated with either one of the NOACs or Warfarin, looking at bleeding. Apixaban versus Warfarin, we know is reduced. Rivaroxaban versus Warfarin, similar as in the trials, and dabigatran versus Warfarin less. So again, what we see in the real world is supported by the clinical trial. Beyond Norway, lower risk of bleeding with Apixaban than with Warfarin, so very much the same pattern as what we saw in the Truven data. And then there's others that we won't go into detail. This one is particularly important because this was sponsored by the FDA, who did their own analysis and found exactly the same sort of patterns as I've described. These are others, so we don't really need to dwell on them. This is ARISTOPHANES, Apixaban, with looking at stroke versus rivaroxaban bleeding. Again, this was a study done, I think this was done in Greece, I think. Anyway, sorry, the US, no. And again, looking at patients who received NOACs and comparing bleeding rates, effectiveness, Apixaban versus River better, Apixaban versus dabigatran better, and dabigatran Apixaban in rivaroxaban in this study was in favor of dabigatran. Safety, all of them were safer with respect to major bleeding. So again, a little bit different from the clinical trials, but all in keeping with the vagaries of what we see in clinical practice. The FDA analysis, again, sponsored by the FDA, seeing the same sort of population, nearly 500,000 patients, NOAC, and comparing effectiveness and safety. So rivaroxaban, same effectiveness, but more bleeding than Apixaban. Dabigatran, same effectiveness and more bleeding, and rivaroxaban, dabigatran, pretty similar. So there are nuances between the studies, but effectively what we're saying is all the NOACs are as good as or better at reducing stroke than Warfarin, and there is caused less or equivalent bleeding to Warfarin, depending on the agent you use and the dose you choose. So really we've said pretty much summed up here. Basically, the the NOACs are a good alternative to warfarin for reduction of stroke and have far safer bleeding profiles than warfarin. So just to finish, I just want to show you how real world data and the trial data has really affected our clinical practice over time. So I showed you a slide like this before, and we got to about 2011 down here, and most of the guidelines are still sort of saying warfarin's a good choice, perhaps you should consider a NOAC. As time has gone on, more and more have said NOACs are the way to go, that they're a good alternative to warfarin, they are safer, they're more effective, and that the recommendations now pretty much in all the major guidelines would be that NOAC is recommended in preference to warfarin for stroke prevention. In the Garfield study, as I mentioned before, we looked at over time the cohorts, 5 to 10,000 in each, and looked at the patterns of prescribing of antithrombotic therapy in treatment naive patients diagnosed with AF. And you can see that the dark blue bars is warfarin, and it's progressively decreasing. You can see the light blue bars are NOACs, and they're progressively increasing. We're seeing that aspirin has diminished considerably over time. But what's a little worrisome is that the proportion of patients who are on no anticoagulant therapy over a 5-year period really hasn't changed. And they're patients who are at risk, and we really have to ask ourselves what disqualifies these patients from receiving a life-saving treatment and that would reduce the risk of stroke and bleeding. In the real world, these results have translated into better outcomes. So this is looking at the UK, looking at hospitalized stroke, and looking at oral anticoagulation use. So as the OACs, whether it be warfarin or NOACs went up, stroke rates started to come down, and the use of aspirin tailed off. So again, implying that as anticoagulation for non-valvular AF went up, that translated into a reduction in stroke. And we saw the same pattern with in Sweden, so in 2012 in orange, and 2017 as oral anticoagulation became more acceptable and safer with the DOACs, the rates of stroke dropped off, but the bleeding wasn't any worse. So basically, again, saying that if we anticoagulate these patients, it really does translate into a benefit, and that the price you pay is bleeding, but it's no worse. It's not getting worse over time. So to finish, this is where we've come from. So we've said that aspirin is debatable. When this slide was made, they were saying it had a reduction. I've shown you that's debatable. But clopidogrel and aspirin is better than aspirin alone, without doubt. The Active-A study showed that. Active-W showed that warfarin was better than clopidogrel and aspirin. And then we have the big studies saying dabigatran, rivaroxaban, and apixaban are better than warfarin with respect to stroke reduction and with respect to major bleeding and intracranial hemorrhage. So this is my final slide, and basically this is Greg Lipp, who's one of the globally acknowledged experts in anticoagulation and NOACs, has basically said apixaban 5 milligrams with appropriate dose reduction in some cases is currently the best documented alternative to both warfarin and aspirin for stroke prevention in a broad population with AF and increased risk of stroke based on Aristotle and Averroes. So I think that pretty much sums up where we are at the present time. So I'll finish there. I'll bid you farewell from Geelong. This is where I live. This is our big hospital here. This is the bay where fishing and yachting is a really pleasant pastime. And I'd encourage you, if you are in Australia, to come on by and see it's the gateway to the Great Ocean Road. So we'll have plenty of time for questions. So thanks for your attention, and we'll speak again later.
All right, thank you very much to Professor Marina for the great and very comprehensive lecture regarding novel anticoagulation in relation with atrial fibrillation. Of course, it will give us a better understanding in the utilization of this NOAC and to help us with the decision of anticoagulation in our AF patients. I'm sure from the attendee here, there will be a lot of questions that will be asked to Professor Amerina. However, before we go further to the discussion with Professor Amerina, I would like to invite our second speaker, which is one of our Indonesian young electrophysiologists, who is Dr. Doni Friadi, who has finished his training in electrophysiology in Korea in 2018. At the moment, he works at Sentra Medical Hospital in Cisalak, Depok, Indonesia. And today he will present a real case study based in Indonesia regarding novel anticoagulation. To Dr. Doni Friadi, the time is yours now.
Yes, thank you very much. It was a wonderful presentation, and I think he is one of the, he involved directly, I believe, in a lot of the trial regarding NOAC. So I think we will have a lot of insight from him about NOAC. Continue with my presentation. Okay, you can see my.
Not yet, Dr. Friadi.
Oh, wait. Okay. Yes, you can see my slide now, right?
Yes, all good.
Okay. Thank you very much for all the participants tonight. Welcome to the Indonesia Heart Rhythm Society webinar. We hope we can share something useful and we can use for our everyday practice. Regarding this presentation, I have nothing to disclose. This patient recently come to me in my outpatient clinic. She's 71 years old with a history of hypertension 10 years ago and have a history of stroke 4 years ago. At the time, I don't suspect about stroke because she seems looks very well. And asked about the history. She said that 4 years ago, suddenly she unconscious and has paralyzed on the left side. But she said she has a complete cover from the incident. So I was surprised, but it's okay. So the patient was, we are talking about the possibility of doing but anyway, the patient he have a quite high blood pressure, 150 per 100 and 98 per minute irregular from echo non-valvular IF with still good LV ejection fraction. Current medication using aspilat, perindopril, and verapamil. Weight 70 kilogram and creatinine clearance 45. So this nice right now she's okay. No paralyzed. Completely recovered from a stroke 4 years ago. And then we have to think, of course, with history of previous stroke, we make sure that the first stroke she can recover fully, but if the second stroke, usually a lot severe. And so what to do, right? So again, using this screening and management of atrial fibrillation, yes, we have found. Luckily, the ECG show atrial fibrillation, and then we should evaluate of AF patient underlying condition like renal hypertension, heart failure, and we should treat underlying condition and manage risk factor. And we should think about what strategy to what kind of anticoagulation in our patient. So again, this patient, we will try to stroke risk in this patient using the CHA2DS2-VASc score and with a prior stroke and hypertension and age in 71 years old and around 6.7% stroke risk rate per year. But it is quite interesting just to show that if we see this slide, this is showing that the risk of stroke using CHA2DS2-VASc score also, but from different country, from Sweden, Hong Kong cohort, and our patient is here. So if we see this again, so what is the risk of stroke in our? It depends what we want to use, right? From the euro, you can have 6 point with CHA2DS2-5, we can have a 6.7% risk of stroke. You can use the Hong Kong data, it will be 12.7%. Using the Sweden data, it will be 7.2%. Or Taiwan data, it will be 6.6%. It is interesting because a little plus. I hope in the future we can have our own this data, so we can interpret accordingly. But that is the future, I think. Every country has its own strategy and individualized management, although in regarding to AF and stroke. So I think everybody is aware about. So if we can see slowly, we have a IF patient, right? Because no mechanical prosthetic mechanical valve, moderate or severe mitral stenosis. So of course the choice is not VKA, because if they have a mechanical or moderate severe mitral stenosis, is definitely vitamin K. We have do the CHA2DS2-VASc score, right? And in our patient, it's actually quite high. Female and more around 5. So oral anticoagulation is recommended. And in step 3, we should begin non-vitamin K oral anticoagulation.
Dr. Doni Friadi, are you there? All right, I think we lost connection with Dr. Doni Friadi. I'm so sorry, I apologize for that. While waiting for Dr. Doni Friadi to come back, I think we will proceed the discussion with Professor Amirina, if that's okay, Professor. Sorry, you are still muted, Professor Amirina.
Okay, yeah, that's fine.
Yeah.
Yeah, no, that's good. I'm happy to come back, and if Donnie comes back, well, we can pick up from where he left off.
Yeah, sure. I think we already have like a few questions over here, Professor
Sure.
Amirina, and to you.
Sure.
The first question is regarding the utilization of NOAC in particular, because here in our country, we are not very used to with the use of NOAC and the justification between each NOAC actually still very challenging. So in your practice, Professor Amirina, how is the justification? How is your preference over each NOAC? I mean, in each in which population you use which NOAC for your preference?
Okay. So look, we're lucky in Australia in that most of the drugs are heavily subsidised by the government, and all the three NOACs, dabigatran, rivaroxaban, and apixaban, are all subsidised here. So there's really very little out-of-pocket cost for the patients. So the characteristics that I use to determine which one is firstly the renal function, because dabigatran is highly dependent on renal excretion, whereas apixaban and rivaroxaban are far less so. So if a patient's got an impairment of renal function, creatinine clearance of 30 to 40, I think apixaban or rivaroxaban would be the way to use them rather than dabigatran. You can use the 110 milligram BD of dabigatran, but even that I'm a little hesitant to do so when it's so dependent on renal excretion. The other considerations are basically dabigatran 150 is the only one of the NOACs that reduced ischemic stroke independently as a separate endpoint. So if you've got a younger person who's got a high risk, then I would probably use dabigatran 150 because it's the most potent at reducing stroke, but the price you pay is the bleeding is the same as warfarin. If you've got a patient who's just on once a day medications, and then you ask them to take dabigatran or apixaban twice daily, sometimes compliance is an issue. So at that stage, I'd probably just use rivaroxaban once daily, but except that it's similar to warfarin in both stroke prevention and bleeding. Other factors are that we've done subgroup analyses in all the studies. I don't think age should be a factor in choosing one of the agents. I certainly think renal function is. And I think basically bleeding is another issue. If you've got a high risk of bleeding, you would use basically the 110 milligrams of Pradaxa or the lower dose of apixaban if they met the dose reduction criteria. So I think there's a whole lot of individual characteristics that you have to assimilate and then make a choice about what's best for the patient in front of you.
All right. Thank you very much, Professor Amirina. I would like to invite the other panelists if you have any question particularly to Prof. Amirina. Is there any of the panelists who would like to ask questions? Oh, we have Dr. Doni back already. Welcome back, Dr. Doni.
I think you're still muted.
Yeah, you're still muted.
Okay. Yeah. Okay. I'm really sorry for the connection. I guess it's in my part then. Shall we continue?
Yeah. Please, Dr. Doni.
Okay. As just like I say, so now we have a good, strong indication to give oral anticoagulant in our patient, but again, to assess the bleeding risk. So this is I think everybody is familiar with the Hasbet risk criteria. She has a history of hypertension. As if right now, the blood pressure is around 150, so not high to 160. have some abnormal renal, have a previous stroke, no bleeding, no history of using oral anticoagulants. She's using only antiplatelet. She's elderly. Drugs, maybe some using aspirate, but I think if we want to, but because no history of using in stanting, or maybe we can stop it after if we would like to try with anticoagulant. So from here we have a Hasbet score is 3 or 4, so it is the high risk for bleeding. So around 3 to 3, minimal 3, we can high risk for bleeding patient. So everyone who takes anticoagulant will incur an increased risk of bleeding. As at low risk of stroke, she may get no clinical benefit from our anticoagulant. But again, unfortunately, a high chest score often correlate with a high Hasbet score. And often these patients do not receive anticoagulation due to high bleeding risk. So we can presume maybe the physician thinking about the high risk bleeding choose to give antiplatelet in this patient. But again, the patient comes, so we would like to try it using our data. This is a general guides about is it warfarin, right? So factor favoring warfarin, if the patient who can maintain at least 6 out of 10 ENR reading within therapeutic range while on warfarin. So I think all the study using to make sure the quality of the warfarin in all the NOAC pivotal study, right? The time in therapeutic range 60%. Maintain at least ENR of 2 or 3 in 6 out of 10 ENR reading. So this, if this patient can do it, but because this patient has no experience with warfarin, so we cannot. Patient unable to tolerate side effects of NOAC, like epigastric discomfort or dyspepsia. Is it significant? Patient with moderate to severe liver or renal impairment. Is it quite severe in our case? Patient with clinically significant drug-to-drug interaction. And what about favoring NOAC? So patient who cannot maintain the ENR, but this patient has no history of it. Patient with difficult access to ENR monitoring or to have frequent ENR monitoring. So Professor Amerina has shown us the 4 pivotal trials of the NOAC. And so this is meta-analysis of the study, so we can have a broad picture of NOAC one-to-one. We baseline characteristic of each the pivotal trial, right? We have RELY with dabigatran, ROCKET-AF, Aristotle, ENGAGE-AF, and combine all of NOAC and warfarin. As we can see in this data, if we combine between all NOAC and warfarin, it seems like all is the same. But again, some insight we can see from this baseline of 4 pivotal trial of NOAC. Patient population who is frail, like old, like more than 75 years old, or like have a history of previous stroke or have a renal dysfunction, usually is underrepresented not so many in clinical, like only 19%, or previous stroke around 30% of whole population or elderly. This is also why we need a real world data applied to our patient, so we can have a more safety management of our patient. And we can also see that although all of it almost the same, but with regarding the CHA2DS2-VASc score, the CHA2DS2-VASc 2 and 3, moderate or high risk of stroke, is a little bit different. The warfarin has lower in the moderate risk of stroke, but a slightly higher in the higher risk of stroke population compared to the all NOAC population. But it is a clinical trial, so that's why, just like Professor Marina said, we need real world data to guide us in our therapy. And so again, I will pinpoint several main points of all the NOAC trials, so we can have minimally a principal understanding. See, so this is again the 4 pivotal trial, each trial representing 1 drug, and we can see from the stroke embolic events that all of the data shows that NOAC is better or favors NOAC. And then in preventing stroke or systemic embolic events. But if we see closely in figure 2, again, the prevention of stroke or systemic embolic events is mostly driven by the success of NOAC in preventing hemorrhagic stroke. Ischemic stroke, which is related to atrial fibrillation, NOAC is almost the same like warfarin, but it has a very good safety in preventing hemorrhagic stroke. So, this is a complication from the drug. Warfarin have a high bleeding side effect of hemorrhagic stroke. And so using NOAC, we will have the same ischemic stroke prevention capability related to atrial fibrillation, but we will have a much better safety in preventing hemorrhagic stroke. And again, this is also better all-cause mortality favoring NOAC. We have to give it. And regarding safety, again, the NOAC have better intracranial hemorrhage, but it is also shown here in efficacy. But gastrointestinal or gastric discomfort will favor warfarin. So patients with warfarin have less gastro bleeding. So you can see here that NOAC is good in preventing hemorrhagic stroke, and the same as warfarin, except maybe dabigatran. But overall, same ischemic prevention capability, but less side effect of hemorrhagic stroke compared to warfarin. And with major bleeding, it is likely more favor for NOAC. So that is the pivotal trial of all 4 major NOAC. So you can see, again, so back to our patient, which of the NOAC will you prescribe to our patient? We have 4 NOAC as of right now. We have dabigatran with 2 doses, 150 milligram twice or 110 twice a day. The Apixaban, 5 milligram twice a day or 2.5 milligram twice a day. or we have the rivaroxaban 20 milligram daily, or we will use edoxaban 60 milligram daily or 30 milligram daily. That is our real problem right now. Again, that is before we can see the pivotal trial meta-analysis. Now, some meta-analyses have been done about real-world data, NOAC, and what meta-analysis of real-world data of NOAC compared to Warfarin conclude that patients with NOAC have confirms the main finding of the randomized clinical trial and strengthens their validity. The real-world data of NOAC is in line with the pivotal trial. And again, another meta-analysis. This one is much earlier in 2018, so much more data, much more trial to analyze. The meta-analysis of real-world Warfarin, the conclusion is NOACs appear to be at least as effective and safe as prevention in patients with non-valvular AF. So we're back to our patient. This is female, weight 70 kilograms, 45, hypertension with previous stroke, drugs of verapamil and aspilate. As you can see, if we are going to use, we have to calculate the creatinine clearance because that is what the major trial use in their trial. So we cannot use like estimated because in 50% of the patient, it will be higher dose. So we have to, if we want to use NOAC, we should calculate the creatinine clearance. Because this is important especially in our patient, in real-world patient. So again, we have back to our patient, we have a creatinine clearance of 5, almost is approved for all NOAC. So all NOAC can be given. But let's look closely. What about dose? Is it we give the standard dose or reduced dose? With creatinine clearance of 45 in rivaroxaban, of course we give adjustment dose because more than 50, no adjustment. With 45, so we probably going to give adjustment dose to 50 milligram. With the edoxaban, it's again, probably we will give creatinine clearance 15 to 49, we will reduce the gram once daily. What about apixaban? Well, apixaban with creatinine clearance 15 to 29, it will be reduced if serum creatinine is more than 1.5 or age more than 80 or weight less than 60. It will be the dosage should not be reduced. What about dabigatran? When creatinine clearance is 30 to 40, 150 milligram twice or no reduction is possible. But we could reduce it to 110 if we have such as drug interaction. In this example, verapamil. So this is the specification product from each of the NOAC. So again, if we're going to use NOAC, I strongly recommend we have to calculate. We cannot use creatinine or estimated GFR, because as you can say, it is their diagnostic for adjustment. So again, this is just to show that there are actually quite many drugs to drug interaction effect of NOAC. So like this is just some of cardiology drug or heart drug that we use: amiodarone, dioxin, diltiazem, verapamil, right? So red is we should not give this NOAC. Our patient have verapamil in orange, so it should we should reduce the NOAC dose. If dabigatran for apixaban, no data. Adoxaban, no dose reduction required, except if we have another factor. So again, this is important if we're going to use NOAC. This is just to show what I said, that actually there are many drugs that could interact with in our patient. We could usually use like amiodarone, clopidogrel, diltiazem. Now with COVID, maybe some antiviral, yeah, verapamil, and then again each. So contrary to our belief that not many drug-to-drug interaction, no, actually not drug-to-drug interaction. So we should be aware of that. And drugs that increase the bleeding risk, such as NSAID, antiplatelet, and so on, we should be remembered. So which of the NOAC that, again, back to our question, will you prescribe to our patient, and then what dose? Well, according to our calculation, maybe dabigatran, we should reduce it to 110. We should reduce rivaroxaban if we're going to use it. Apixaban is safe, so do not need any dose reduction. And adoxaban should be reduced the dose to 30 milligrams. Again, this is dose reduction in NOAC. We have to ask ourselves, is it safe? I mean, because the population is underrepresented in pivotal clinical trial of NOAC. As you can see, the frail patients is only around 30% of, or 19%. So we should see the real world data. But but I hope maybe in the future we will have many real world data to guide us. So is it effective to reduce? No. So we have the meta-analysis of real world comparison of reduced dose of NOAC versus Warfarin. This is from July 2019. We have like 14 cohort study, and they conclude comparing the reduced dose of NOAC compared to Warfarin, well, associated with decreased risk of stroke or systemic embolism around 20%, ischemic stroke 30%, major bleeding 30%, intracranial hemorrhage almost 50%, and gastrointestinal bleeding, but not all cause death. In the subgroup analysis, all NOAC users had a lower or similar rates of thromboembolic and bleeding events, and the reduction in stroke or systemic embolism, bleeding, and gastrointestinal bleeding were more prominent in Asian than non-Asian. So luckily, in this real-world meta-analysis of reduced dose of NOAC versus Warfarin in Asian population, from this meta-analysis of real-world data, reduced dose is non-inferior in Warfarin in patient with atrial fibrillation in Asian population. So we have quite support for reducing dose in our case. If you see, there are some issues regarding NOAC that still we have to be careful about, and we will wait and we will see about data, more data, like phenomenon of rebound hypercoagulability. So what is this? This is, there are many reports and trials that affecting patient permanent discontinue of using NOAC. And so, but luckily, this is, I think the data mostly from rivaroxaban and edoxaban. And dabigatran or apixaban, not yet data about it, but I don't know if it will conclude with them or not. But anyway, rebound hypercoagulability, when the trial is the first time from the rivaroxaban trial, if I'm not mistaken. So the patient, the population that using NOAC, after they stop the NOAC, in just 2 to 30 days after they stop NOAC, the risk of ischemic 20 times. So that's quite surprising. So, and then some case report and small trial also come. So in patient stop using NOAC, in that data, it showed that there is a high possibility of increased ischemic stroke risk. The first one, 20 times higher than normal. So it's very surprising. So I think, but maybe we can have more insight from Professor Amirena. But they said that it is because the difficulty in reaching target ENR. So when you stop NOAC and then you switch to warfarin, do not expect that the warfarin will immediately achieve the target ENR of 2 or 3. This is from the investigator of the pivotal trial said that patient who stopped from the NOAC and then switched to warfarin, they say that they don't, majority of them don't reach the ENR target of 2 and 3. So that is why they have increased stroke ischemic. So what I mean from this point is that because NOAC is quite expensive, if you are going to use NOAC, we have to see about how to, if one day the patient is not capable of using NOAC again, maybe like economic reason. So we have to understand how to change it. And about universal agent also and cost of NOAC. So in summary, real-world data of NOAC confirm the finding of NOAC main trial, that NOAC have better safety in hemorrhagic stroke and have the same benefit as the vitamin K in preventing ischemic stroke. The use of reduced dose NOAC is non-inferior to warfarin in patients with AF, in particular Asian population. But new data hopefully will help us to treat AF patients in our country with NOAC that is safe, clinically appropriate, and cost-effective. Thank you very much.
All right, thank you very much, Mr. Doni, for a very interesting real case scenario in Indonesia. So we move to the next session, which is the question and answer from the audience to both speakers. I think because the use of novel oral anticoagulation in Indonesia is more to the challenge is more to the use because of the price is quite expensive and it's not well covered by the national insurance. We more tend to use the vitamin K antagonist instead of novel anticoagulation for anticoagulation in our AF patients. There is a question from one of our audience, Dr. Muhammad Faisal Adam, to both speakers. I think this is related to the technicality. So he actually asked the question, if there is a patient come to us with atrial fibrillation with high chart fast. However, because it's not covered, NOAC is not covered by the national insurance system, and then the hospital doesn't have the ability to check the INR to see the whether the warfarin has achieved the therapeutic level for this patient or not. He actually asking, is there any other suggestion how to measure the successful of anticoagulating patient with warfarin if we can't check the INR for this patient? Probably from Prof. Amerina or Dr. Doni can give the suggestion. Thank you.
But yeah, I could make a comment. If you can't check the INR, then you can't monitor anticoagulation. It's as simple as that. You don't have an option. Yeah, the only other alternative that's not ideal is that aspirin and clopidogrel is better than aspirin alone at reducing stroke, but a little bit of increased bleeding, but it's not as good as warfarin. So if you can't monitor and you want to give better therapy than just aspirin alone, aspirin and clopidogrel is better, but if you can't monitor the INR, then you shouldn't have people on warfarin. It's just too dangerous.
Yeah, all right. Thank you, Professor Marina. Dr. Doni, do you have any comment regarding this?
Yes, it actually is a real problem. So this is a real world problem in in our everyday practice. Usually, with you have to spend a little bit more time educating the patient, because just like Professor Marina said, you have to check the ENR. So what we can do, usually we check in more longer time, like 1 month or 3 months, and sometimes patient, if would like, will can and willing to pay for the cost of the ENR examination. But just like Professor said, if we can ENR, we cannot use warfarin. So it's maybe more education, and maybe definitely not ideal. That's why if it's like that, we have a place for NOAC, right? But if ENR is not, it's like very high.
All right. Yeah, thank you very much. There is another question here. In the case that you presented, Dr. Doni, there is a question whether the use of aspirin alone or with combination with warfarin is actually suitable for that condition. And also in condition which switch the aspirin into NOAC, how do we normally switch the medication? Do we just switch the medication directly from aspirin to NOAC, or is there any overlap time for the switching? Thank you.
Yeah, I think aspirin is not doesn't have any place in this. We should check the ENR first. We see the ENR, and if it less, we target the ENR, it should be around 2, and before we can give warfarin if you want to change. So check the ENR first. But I think suddenly, but usually patient I mean, usually you should not stop the NOAC suddenly, but again, patients sometimes just say, it's too expensive. Can we change it now? That could be a problem because we should check the ENR first before the NOAC. Maybe Professor Amerina have more insight in this problem.
Yeah, I do a little bit. One of the, except at the end of the rocket study, there was patients were just taken off study medication, and their physicians were told them, you do whatever is appropriate. So if they were on warfarin, they continued on warfarin, and their INR stayed therapeutic. The patients who were on rivaroxaban stopped their anticoagulant, and then there was about a 3 to 4 week time period where their INR was less than 2, and that's so it's not hypercoagulability, it's that they had an INR that was low for a substantial period of time until it became above 2, and that's when they had the stroke. So in Aristotle, we recognized that, and we came up with a different strategy and said that at the end of the study, if the patients who were on Apixaban were going back on warfarin because there wasn't an extension after the study, we said they had to go on subcutaneous clexane on a daily basis until their INR was above 2, and we didn't see the same problem with stroke. So it was really, it's not stopping the NOAC, it's the lack of, it's the time to get the INR therapeutic that was the problem with the excess stroke after rocket. So you can use bridging clexane. I'm not sure if that's available or widely used in Indonesia, but certainly in Australia, if we're going like that, we would bridge the patient with clexane until the INR is consistently above 2.
Yes. So again, one of the benefit of NOAA is a very fast onset and offset. So it's very beneficial if you have temporary, right, or bleeding, but because it's very fast offside or stopping in 12 and 24 hours, the articulation level will stop. That's why you need some bridging before changing to the warfarin.
And the other thing is underappreciated is that the NOACs produce full anticoagulation within about 2 hours of taking the tablet. So it's not like warfarin where it has to catch up. You take the tablet, and then 2 hours later, you're fully anticoagulated. And that's important because in the early days, what happened, say a patient had surgery, they were on a NOAC, and the patient had surgery for whatever, hip or whatever, and the surgeon said, oh, well, they think it's like warfarin, you start it up and it won't be therapeutic for a few days. And they start it up and the patient bleeds because they're fully anticoagulated pretty much as soon as they've taken the pill. So we have to educate the surgeons that it's not like warfarin, and think of it more like clexane. So the way I used to describe it to surgeons, think of it like oral clexane. Same time period, 12-hour half-life, same dependence on renal excretion, and basically same degree of anticoagulation. So when you put it in terms that they can sort of understand, then we had far less problem with inappropriately early restarting of anticoagulation after surgical procedures.
All right. Yeah. So now we come to the end of the session. I would like to conclude our session today. Thank you for Professor Amerina and Dr. Doni Friadi for giving us a very comprehensive and great lecture with regards to the use of the novel oral anticoagulation. In summary, in patients with atrial fibrillation, thromboembolic prevention is very important to prevent morbidity and mortality. A lot of publication available to support data regarding finding the balance between the risk of embolic stroke and bleeding. And for this reason, I think NOAC is shown to be superior compared to vitamin K antagonist. Unfortunately, in our country, this is very challenging because of the price that is really makes the challenge to give this prescription to the patient. However, considering the benefit, I think we should try to give the patient what is the most beneficial for them. I would like to express again my gratitude to Professor Emerina, who already available to present in our forum here. Also for Dr. Doni Friadi to share a great case from our country. Also, I would like to thank you to the Indonesian Heart Rhythm Society Committee for the effort to hold this event, even in this pandemic era, through the Zoom. And also, again, thank you for our sponsor, Pfizer, to sponsor this event. And especially for all the audiences, thank you for the attendance and the participation in this event. And I will close this session and give the forum back to the committee. Thank you very much. Good evening.
Terima kasih
Thank
kami
you very much.
ucapkan kepada Dr. Dian Munawar,
Sure.
SPJP,
That's a
sebagai
pleasure.
moderator. Terima kasih kepada Dr. Doni Friadi, SPJP, atas waktu dan ilmu yang sangat bermanfaat pada malam hari ini. And also thank you so much to Professor John Amirena for sharing more knowledge for us tonight. Untuk webinar minggu depan dapat dilihat on screen masing-masing peserta. Jangan lupa untuk selalu update webinar Rina HLS untuk memperdalam ilmu aritmia khususnya di Indonesia. Selalu update sosial media kita karena setiap minggunya akan ada update link untuk webinar selanjutnya. Terima kasih kepada para partisipan. Sampai ketemu minggu depan. Selamat weekend. Wassalamualaikum warahmatullahi wabarakatuh.